See that we have several members of the public as well as staff of Augusta, Georgia. And please bear with us. As you know, we are sitting in uncharted seats as far as I'm concerned as it relates to those of us that are sitting here. But this is our first EMS Subcommittee meeting for the City of Augusta as it relates to EMS services. We again appreciate your time for those of you that are viewing us online and for those of you that are here in the audience. I would like to start off by introducing myself. I am Takia Dowse, the interim administrator who will be acting as your chair for the EMS subcommittee. And we will start off with introductions down to my right. Ms. Sams.
Hi, my name is Jerry Sams. I'm the procurement director for the City of Augusta.
Good afternoon, Antonio Burden, Fire Chief, EMA Director for Augusta Fire Department.
Daniel Dunlap, 911 Director.
Dr. Becky Abel, I'm an EMS physician.
Daryl Davis, EMS Coordinator, Doctors Hospital of Augusta.
Wayne Brown, General Counsel, City of Augusta.
Thank you all. The purpose of our meeting today is to have introductory related dialogue as it concerns our EMS contract with Central EMS, who has been awarded the zone as Augusta's zone provider. We have representatives from Central that are also here today. Mr. Coker, would you like to introduce yourself as well as those who are present with you today?
Yes. I'm Gary Coker, President of Central EMS, and with us, Brian Gibson.
Hello, pleasure to see you.
Brian Gibson.
Mr. Coker, if you would, please pull your
mic
microphone
down.
down and speak directly into it.
That's a big one. Yeah.
I was trying to speak out of this. So, all right. Gary Coker, President of Central EMS. Brian Gibson is our CEO of our parent company. And then Corey Thomas is our Vice President of Operations for Central EMS in Georgia.
Thank you so much for that. While we continue along with the dialogue today, it is particularly important that we understand that we do not expect to conclude discussions today. It is designed for us to continue to flush out a product that would best suit Augusta's residents and those who visit our Garden City. In doing so, at the conclusion of this, at this point, we've already scheduled an additional meeting, but at the conclusion of our meetings, we expect to present the commission with a contract that is agreed upon by both parties. Again, we do not expect discussions to conclude today. So, Mr. Coker, with that being said, would you please provide us with our current state of the National Emergency Medical Service environment?
Yes, ma'am. And I'm going to have Brian Gibson to speak to that because I'm the Georgia guy and he has more of the national picture. Please.
Thank you.
Hello, good afternoon. I think it's afternoon now, right? So, first of all, Brian Gibson, CEO of Priority Holdings. I first want to say that we are very excited about the opportunity to be able to work with the EMS committee. We take this task actually very, very seriously. We understand that our role is to be a public-private partnership and also will provide transparency. So in the transparency, I wanted to be able to share with you what I know about EMS related, since we operate in almost 16 states now, 500,000 employees, 5,000 employees nationwide, all the way from the West Coast to the East Coast. I don't want to sit up here and say it's easy. So I wanted to make sure that I gave you the information of the environment that we're operating in, not only locally but nationally. Just yesterday, I received an email from a state that we operate in that says 50%, actually 67% of all EMS personnel from EMT to EMTA to paramedic are not renewing their license. Didn't renew their license. So we're dealing with a underserved, undertaught population base for our employees. Coupled by that, we're also having hospitals, what I would also call new practice arenas for paramedics and EMTAs, which traditionally were in ambulances and might somewhat moonlight in some ED, but now are working in ERs, cath labs, critical care units, and hospitals across the United States, addressing the nursing shortage that is also occurring in the United States. So that has cost the EMS agencies around the world, around the nation, more money related to the hourly rate and the benefits packages. So we're dealing with Amazons of the world, we're dealing with hospitals and other environments that are now considered not traditional practice of EMS. Okay. For the first time, and I'm very happy, being a practicing paramedic, that you don't want treating you, because I'm not that very good at it anymore in the streets, but that actually paramedics aren't working for minimum wage anymore, and that's a good thing. The problem with that, though, is we have no problem with paying it. We believe they deserve it, and we believe that now the economics for paramedics and EMTs need to come up across the United States, and it is. But we're also trying to find ways of paying for it. Ambulance services rely mostly on Medicare and Medicaid throughout the United States. We don't get to change our rates. We get no more money from Medicare and no more money from Medicaid. We're on what you call a fixed income. So when we're on a fixed income and our prices go up for fuel, for doable medical equipment, for rolling stock, for ambulances, and labor, it puts really a big strain on what we consider an essential service throughout the United States. Now, we as a company have taken, along with our EMS partnerships with the associations around the world, including Georgia, have worked on programs such as the UPL, which is a Medicaid matching fund grant that we're allowed to tax ourselves, if you will, and then we draw down more money. So we're going to bring that to bear in this community. There's also the monies related to assess and refer that we're talking about bringing and working with the states, and they are responding to help us generate more revenue to help pay for this essential service. As far as training of EMTs and paramedics, I wanted the committee to understand that the state has worked with us here in Georgia actually very well and relaxed some of the requirements for us to be able to use training programs at other institutions as opposed to just college, junior college functions, which has helped. Also relaxed some of the regulations related to drivers and EMRs to help us get new people into the workforce that otherwise couldn't get into the workforce, is starting to drive ambulances first. We worked on that the last 24, 36 months, I think, Gary, in the state, and we were successful as an industry to do that. I wanted to start this off not saying, hey, you know, there's a reason for the money, but I wanted the committee to come away and ask more questions to basically understand, hey, it's not like it used to be. It is just not. Everything we touch is costing more money. Everything. Insurance, fuel, medical supplies. It all costs more money. On top of that, we're having what we call APOD, ambulance patient offload delays. It's not the hospital's fault. It's they're having the same problem. They don't have staff. They're having trouble moving patients. Patients are also trying to figure out how to access health care. Medicaid and Medicare, for us, a lot of it is just, how do I get health care? It's not, do I need an ambulance? Quite frankly, a lot of people that call ambulances don't need them. But it's how they get into the healthcare system. So it's an access to healthcare issue that we think is part of the social determinant of health that we need to help answer, along with just providing good response times. It's how do we help people get to where they need to be the first time, because that takes the burden off the hospitals, that takes the burden off of the EMS provider, and it helps us be more efficient, which then turns we can provide the right care. Instead of being tied up on the patient that we shouldn't be tied up on, we're tied up on the patients that really truly need us. That is where we're at in the State of the Union right now. It costs more money. There's not hardly any more money, and we've got everybody downstream in the same situation, which causes us to have more time in what we call a task time. From the time the call is received to the time the call is finished, it has been elongated. It is taking longer and longer and longer for us to do a trip, and we need to help and figure out ways to shorten that task time, to keep our assets deployed to those patients who really need us. That's the State of the Union as I see it.
Thank you so much for that. As it concerns Augusta's goal for our EMS system, there are several things that we want to take into consideration. The first being that we want to ensure that our system is clinically sound. To assist us with that, we have here with us today an EMS coordinator in Daryl Davis, as well as a emergency medical professional, Dr. Becky Abel. So thank you for acting in a advisory capacity. That also includes our response time standards, which are equally just as important to ensure our residents and visitors are attended to as soon as possible. We want to make sure that the system is operationally efficient as well as financially sustainable. Mr. Coker, could you please speak to us surrounding how you would propose a solution that is clinically sound?
Yes, ma'am. I think that the first objective that we would have would be to try to address response times and exactly what those response times should be. And we're going to need the help from this committee for us to help to understand what your community desires, what your community needs are in response times. You know, is it a 4-minute response time? Is it a 10-minute response time? Is it a 15-minute response? We don't have the answer today, and so as we go through these committee meetings, we want to be able to try to determine the response time. Now, there's some other clinical issues. I'm going to have Brian to speak to those, please.
So, thanks, Gary. On the clinical side, we would like to talk to the committee about there needs to be a clinical committee, right, that understands what we're doing related to actual care. Right. So the only reason we're here really is to make sure we're providing the right care at the right time and that we're actually getting the patients what they need. So we're probably going to talk to the committee at some point to see if you don't have First Watch, it's something that we should consider. First Watch is what I would call surveillance software that essentially digs into our database, tells us whether our paramedics or EMTs or any of our clinical staff in conjunction with the fire, assuming they want to work with us on this, but as part of the questions, right, is that it sits there and says we got a success rate of X, Y, and Z on intubations, a success rate on IVs. So the clinical standards have to be set, which we will work with our medical director, who we want to jointly work with fire, hopefully have the same protocols and everything works so we have the right circuits together. But the committee needs to be tracking actual performance of each employee and how they're measured. Right. So are we giving the right medications? Did we follow the protocols? So that would be my recommendation.
Chief Burden, do we have the First Watch program that he is speaking of?
No, we currently don't. However, our medical director, along with yours and those members, our EMS coordinator, look to work with you to establish those opportunities. I was really glad to hear you mention things like needs assessment and demand analysis, because those, when you're building a zone, that historical data really tells you what's actually needed in that zone. So we talk about response times, when we talk about the number of units that are needed, that demand analysis really tells you. And so based on historical data, we can really develop and design a system that will meet the needs of the community. So looking forward to seeing what your consultant bring back as it relates to that.
Yes, sir. And if I may, is that we typically hire Washington Associates to do our temporal demand analysis. And we I don't want to hire them and then the committee not bless them, right, as to work with them, right? I don't want it to be a one-way streak, is what I'm trying to say, right? So I want you to have the opportunity to meet, understand, it'll probably be Zoom, right, because they're in New York. But they provide us the temporal demand analysis. So they tell us the peaks and the valleys. Instead of 824s or 1024s or 12s, whatever, they would in turn tell us what we need where, in theory. It's how we operate, right? So we can have a pretty high certainty that the demand meets the supply actually meets the demand, excuse me.
Okay, I know that you mentioned a possible third party.
Yes, ma'am.
and securing data so that you could be more, so that you could make a better decision as to how many ambulances and everything and identified locations, et cetera.
Right.
We are in a very short time frame. If you were to hire such a person, do you think that they would be timely in getting the information back to you in Augusta?
Yes, ma'am, we'll have to, or it won't do us any good, right? So we would need to hurry. I need to follow up with Washco and Associates. I've been working with them on some other projects. We're keeping them quite busy.
Okay.
But I'd like to get that date of when they think they can be done and present it to the committee. We would have them, in theory, present it to the committee so that of their recommendations of how they see it and what they see. They're a little hamstrung related to the data that they have, right? All we have is the state data. But to answer your question shortly, sorry, yes, ma'am, we would give you a time when it has to meet in the time frame. But we are hamstrung on the data, and we need to have some discussion with some people who are actually involved in the transports every day around it, related to like the fire department and the 911 director and his staff, to understand what the task times are, what they're seeing. It's a collaborative approach, and the drive times. But yes, ma'am, we've got to get it done quickly, because to me it's the operating system. It's the real brains of it.
Thank you.
Yes, ma'am.
And are you suggesting that Augusta procure this First Watch application immediately, or is this something that we could look at down the line?
No, ma'am. It's. I don't think Augusta is part of our operating entity. It's our expense, right? So we would provide First Watch. We would provide also Marvelous. We're suggesting Marvelous is what we would like to use. Marvelous is a product that allows us to have amoebas around ambulances that can give us response times from the truck live.
So both of these applications, Augusta personnel, authorized personnel, would have access to the data that's provided.
Yes, ma'am. So we have looked at the requirements for your current contract that you asked for and went through that and said, okay, we're, on the technology side, what do we see, right? So GPS, AVL standard, MDT's standard, right? Marvelous is an upgrade we'd like to suggest that we put in. First Watch is an upgrade. Also, First Watch also gives you data for if I'm having 16 drownings in a certain block of a town, that you now know how to target that block to go do drowning prevention. Or if you're getting multiple, it's a surveillance software, and it gets sent to the health department if you choose to, the hospitals. So you can say we've responded to 22 virus or stomach virus complaints in the last 12 hours in this 12 block radius. So there's a food poisoning potential or consistent, constant types of problems that you otherwise would be finding later down the road if they went to 12 different hospitals, right? And it gives you information instantly that allows you to act as a community from a health standard standpoint of view. That's just one of the things that First Watch does.
So just to clarify, I'm familiar with First Watch.
Okay.
I used it at a previous location that I was before I came to Augusta. So you'd be looking to connect that directly to our CAD system. So we're just looking at working with our CAD vendor for an interface.
That's correct.
Some of the things you just mentioned, if there's just a keyword that we're looking for, you can set that up within First Watch to pull you all calls that had that keyword associated with it.
That's right.
If you're talking about, would you say back pain? You want to see all the calls that had the word back in it that was typed in or referenced within CAD for the last 6 months.
That's right.
It can give you that data right away.
That's right. You'll know if you have a COVID outbreak, if you have a loss of taste or fevers or your keywords, then you'll go boom. Before, honestly, you'll know before the health department does, because you're seeing most of the calls come in.
And some of those triggers can send you alerts if you set them up to let you know, okay, you've had a spike in this incident type within this time period or within this location.
That's right.
That's right. Okay.
So that we're suggesting, we think that a system the size of Augusta and the growth that Augusta has, we need First Watch for multiple reasons, not just for our clinical side, which is what we would use it mainly for, right, is our clinical side and also billing side, but there's a whole social side of that, right, and prevention side of that. The Marvelous system is more for deployment. Okay, so it is where a communication system status controller can sit there and look at the amoebas as they're moving down the road, and the amoeba changes based on speed limits, traffic, and whether there's closures. And so it sits there, and it's a way of basically a communicator, system status controller, I'm not sure what you call them, can have overlap, right? And so it gives you a better visual of response. The posting plan and the temporal demand analysis will come from Washco and Associates, that we would say if we only have 2 trucks, where do we put them? If we have 4 trucks, where do we put them? If we have 5 trucks, where do we put them? It's more of a response times to try to help ensure that we can meet the response times that are out there that you request, right? So if you tell me you want X response times, then our demand would have to be built to try to meet that. That's why when we said, hey, you're asking for X number of ambulances, let's run the data to make sure that really gets you what you think you're getting. Right, that's all I'm asking for. That's why I've been stepping back, and that's why you're hearing me getting a little hesitant, because we want to make sure that we're not putting money in the system where it doesn't belong. Right, we may need 20 ambulances at 2 o'clock in the afternoon and 6 at night, but after 3 o'clock, or it may be the other way around. But a static 24 might not give you what you need at night. I mean, during the peak at day, and it may give you too much at night. It's just an allocation of resources to make sure we get the right response times.
You know, not to get too far into the weeds, but since you mentioned posting plan, we've seen programs like Deccan Live Mom or Optima Live.
Oh yeah.
In terms of those programs that are around the country that have realized lower response times because of posting. So,
absolutely.
Yep.
Yep.
It's also my understanding, too, that the Marvelous system is the prediction of where the next call may come, correct?
That's correct. That's right. It's a live posting plan, a live demand analysis, that once we have the 20 week, not to get in the weeds, Chief, right, to what you said, but my goal here today was to leave the committee with more understanding of what I'm trying to accomplish. And what we'd like to do is we'd like to have the data of 20 weeks, Mondays, 20 Tuesdays, 20 Wednesdays, 20 Thursdays, 20 Fridays. And we run the data. And that doesn't, it's not once and done. That's constantly. We constantly run that, you know, as we get more. And there's seasonality, and there's big events that are outside of the norm, right? The Augusta National would be outside of the norm. That would tell us, okay, we want to run an operating system that sustains the normal business of healthcare within the community for episodic care for 911, but we're going to have things like Augusta National that don't just happen on Augusta National's property. They happen everywhere else in the city as well because of the added people in the environment. So we have to be ready to change. But Marvelous does give us the ability, once we have a baseline, to continuously improve it on the spot. And it just constantly gives us data.
Please.
So then we would have access to the Marvelous within the 911 center to make the determinations for, or is that something that would be used?
The way we're looking at this is, we're not the dispatch center, communication center in this. We're looking for y'all to do that, assuming that's what you would agree to. We want you to have command and control of all the vehicles and staff. We want to agree on the demand and deployment of those assets, meaning we want to agree that we're all running it right. The 911 center, if my choice would be, is that you're controlling the assets, you're doing the posting plan, you're doing the dispatch, you're handling that. And the reason I say that was one of our questions, is that takes cost off of us, right? I mean, let's be transparent. That's what I said earlier in the committee meeting. It's if not, then I've got to build a whole cost center. Comm center. I've got to have redundant systems. I've got to have, and so the more we can take advantage of what's already in place and the expertise that's already there and provide transparency at the same time, it's a win-win for us and you. So if you're willing to provide communications for us and dispatch for us, we're willing to use it.
So in other words, you're saying 911's helping the costs go down. No, I'm sorry.
That's right. Yeah, but at the same time, I think that you take that time away, because if you take the call in your 911 center and then you try to relay it to the next dispatch center, and then they've got to relay it to the ambulance,
Yes, sir.
that takes time, and that takes time on a response time where a person may be in dire need. You know, and so we want to eliminate that part, number one. Number two, you've got the total control. We're not controlling the ambulances. We provide the ambulances. You, the county, control the ambulances and what their responses are and how they're moving and what their movements are. And then you also have the data so that you can analyze it and look at it and say, okay, we need to make changes. All those things happen with these systems. This is software that we've used in other places, and it makes it to where your system will work better. And at the end, all that makes is lower response times,
Sure.
and which is better for your citizens overall.
That's right. We agree.
Now, Mr. Gilmore, we have communicated through previous draft contractual documents. Again, I state draft documents, outlined response times. Do I understand you to say that your vendor, Washco, would be the entity to propose those response times versus Augusta stating what we would like for them to be?
No, ma'am. Thank you for the question. No, it's what if this is. I'm not trying to set expectations, but I just don't know, right? I truly don't know. But what if the money that was proposed in the past would get you better response times? What if the number you proposed that was proposed in the past for subsidy didn't meet that response time? All we're going to ask Washco and Associates to do is to say, here's the response time you've requested currently, 12 minutes, 90%, 15, 90%. How many? He doesn't give us the cost. He gives us the number of trucks, right? His team gives us, here's the number of trucks that we think needs to be staffed in that community to meet those standards. Then we would build a budget together with finance and the county to literally sit there and say line item A, B, C, D, and E are transparent. We've got other questions coming for you, okay? Okay, dispatch is not part of the cost. Comes off, right? Call it, I'm not asking for this, but I'm giving you examples. The county purchased the fuel, so it's cheaper, right? There's no taxes. I'm not suggesting it. I'm just giving you I'm up here on the fly. But there's other things that the county can provide. Housing at the fire departments as opposed to us renting spaces, throughout the community, right? There's a lot of that can reduce the cost. As far as the response times go, if you want 12 minutes and 15, he'll build the system for 12 minutes and 15. But if the money came back and said, hey, I can give you 10 minutes at 90% for, in the same hemisphere of price, why wouldn't we do that, right? Or you may choose, no, we want subsidy decreased, right? So we're going to stick to 12 and 15. That's all I'm saying. We wanted to be able to meet your standard and then talk about other options. And it could be that he's saying, we can't come anywhere near that. You know what I'm saying, as far as trucks, and we can tell you the budget. But the idea for us was to be transparent and all that, right? So I would like for him to tell us the number of trucks it needs to meet what you've requested now, and then for us to have some what-if scenarios for us as a committee to talk about.
What is your estimated time frame in which that information could be returned for us to review? Because as Director Sams mentioned earlier, we have 7 weeks until your planned deployment date.
Yes, as we told the commission, we will be operating, I'm hoping that we get this done, but we're going to be operating anyway, right? So I don't want the date to scare anybody. We're coming, right, one way or the other. But usually from Washco and Associates, it takes them 2 weeks if I can get their time, right? But they are, I got to be honest, we're working on a ton of stuff with them, and but I'm going to try to pull them away. They were going to be available today to meet and talk, but they'd have to be a Zoom. But we can coordinate that. But we're already got some data to them, and now it's just trying to get them. We've got the state data to them, and we're trying to get it categorized. We're probably going to need some help from members of the committee giving us their input of their knowledge of the system as they see it, because a lot of the data is not there, and we're going to have to be trying to put some pieces together.
Okay, thank you for that.
So I'm hoping for 2 weeks, just.
Okay, sounds good. Let's talk a little bit about how you view this system being operationally efficient, and what are your plans for that process?
Well, that goes back to the demand analysis, the temporal demand analysis, putting the number of trucks on when they need to go. That's really what it's about, okay?
Do you have a mutual aid plan?
We will seek mutual aid plans, absolutely, because we're going to staff 2 standard deviations. Most models, we staff 2 standard deviations above the norm for the SSM plan, meaning we will have 2 trucks on more than we normally would for the historical data, right? Because we got to prepare for we got that wrong, right? In our business, we can't not have, we're not allowed to not show up, and so we have to be there. We will seek out mutual aid agreements with surrounding counties, and we'll have to do that, right? Not only just from us, but from the state's coverage. We want to make sure that we can meet our needs. So.
Yeah, there's, I think it's a half a dozen surrounding counties that surround Richmond, and we'd work with each one of them because one's on the east, one's on the west, so on and so forth. But the mutual aid agreements are only for crisis overloads and should rarely be used. Our system should be planned well enough to where we're able to use our assets here in order to make your coverage and make your response times work. Mutual aid is the one-ofs type of
It
situation.
shouldn't be a
we call
norm.
them.
It should be the.
That's the outliers.
It should be the what if.
Should be the outliers.
Thank you for addressing that as an issue, the mutual aid. I have a question, though, that concerning the current employees of companies that that they've worked for and they would like to come and work for you. How did you handle that? Where are you on that? What kind of plan do you
Give
have?
an update on how many.
So, again, Corey, Vice President.
Now, Mr. Thomas, before you speak, we do have a section related to human resources. I think that would be best discussed in that section.
Okay.
So let's wait a while for that, because I know we do have some other questions relating to human resources. Next, a topic that has been very popular is one in which we make certain that we craft a system that is financially sustainable. And you've already communicated publicly, as well as in other meeting sessions, your intent to have a 10% profit. Speak a little bit more about that, as we know that that's not information that you can communicate today, but just give us a little bit more about how that framework will look.
Absolutely. I appreciate the question, too. So, look, that's not normally how we do it. We normally bid on something and we give a price and the county picks the low bidder or the appropriate bid, okay? The reason we proposed this was because the transparency we thought would be needed. There are some people that we've talked to who are saying, hey, I don't understand this 10% thing. And so we're just being honest. We have to make 10% for our investment. That's it. That's what I'm looking for. Now, I can bid it as a sole price and say to the committee, it's X millions of dollars, or it's X, whatever the number price is. But we got a sense from some people that they weren't really sure that the system really needed that. How do I know that it takes $2 million a year? How do I know that it takes $1.9 million a year? And the idea for us was, okay, well, let's just be honest about it. Let's be open and transparent. We were trying to show and be open about we're investing millions from a net working capital standpoint of view and a rolling stock and the equipment, that we have to return a profit. That's the way the business works. Now, we could do it blindly, like I said, and give you a price, or we could be honest and say, here's what the expenses are, which I alluded to earlier about a budget, and here's the revenue. So we were proposing that we actually set up a lockbox for this community related to its 911 transports that we can report to and say, we've collected X millions of dollars from this community related to 911, and here's the deficit that is needed to make the system work that you have requested, right? And that's all we were trying to do. Now, as far as rates go, there was a question about how to make it efficient. Rates came up. Are we okay with the 1750? Are we okay? You know, whatever. The way we look at this is, look, the only place that we can actually collect more money on a rate. So let's just say hypothetically, not saying this. So for the online crowd or for the group here, we're not implying those rates need to go to $3,000. Okay, I'm just picking a number. But what I want you to understand is if you raised rates, a base rate, the only place that it actually falls through is commercial and maybe self-pay. Maybe, probably doubtful. Medicaid is the same, Medicare is the same. So rates become a diminishing factor after a certain period of time, right? Because the only place you can get money from that is the commercial. And that's assuming that all of that's working correctly. So rates, we would sit down when we do our budget and be transparent of how much money we believe based on historical working with the hospitals and some other systems here to get a better idea of what the payer mix would look like, so we can apply a payer mix to the revenue side or to the actual money coming in the door, so we can project what we think the revenues are for this market, and then we can show you against the expenses and how big a deficit that is. That is why we proposed a 10% is part of our transparency, not because I'm just telling you what I have to have. I don't care if it's 10 ambulances or 2. You know what I'm saying? I just need 10%. But if you, to make the system work for us financially, but I wanted to be able to show you that I wasn't running and buying a house on a ski slope. So.
Is this similar principle or practice, was it used with your current contracts that you have in force?
No, ma'am. No, we usually just, accounting puts it out to bid and says we want X, Y, and Z, right? And we say, here's the price. And that's how we typically do it. And I can do that here, be happy to do that, but I was just trying to help you understand where the idea of the money came from. This is more transparent. Most counties they ask for a price and they get it, just like they're bidding out roads or anything else. This was our attempt to be transparent, that's all, not to be problematic.
We certainly appreciate that. However, since your new model is something that you want to present to Augusta, it hasn't been a proven success any place else for you to identify your costs. Would it be impractical for Augusta to ask you to present both models?
No, ma'am, I can do that, certainly, I'd be happy to.
We would appreciate it.
Yes, ma'am.
Thank you.
Thank you so much for that. Now, concerning how our system design, it will encompass several factors such as data collection. I know that you would like to have a joint medical director. We'll be more than happy to speak a little bit more about that as well. In addition to unit deployment, human resources, where I know we have several questions, as well as the fire department coordination, where Fire Chief Burden will act as our contract administrator, as well as your direct contact. Any required reporting measures, our technology needs. We have representatives here today from our Information Technology Department. Tamika Allen is our Chief Information Officer. And then we want to talk a little bit about our business model. So let's start the conversation with our clinical data collection. In that, you would like a joint medical director. Augusta is not opposed to that, but tell me from your standpoint, what benefits do you see this joint medical director providing?
The way I see a joint medical director working is, and the reason I would suggest it, is it's a continuity of care. Right, so we have paramedics, EMTs functioning on a set of protocols that the fire knows that they're functioning on. Let's say that fire shows up with their medical director protocols and is treating a patient a certain way, and our system shows up and we treat it a different way. Or there's different circuitry, right? It goes into not only just the clinical and the protocols side of that, but it also goes on the supplies that we use, right? Do we use the same IV catheters? Do we use the same defibrillation pads? Are we using Zoll over here and Phillips over there? And so it's a, when do we do this? Do we do resus? Do we not? I just want us to be on the same page so that when we show up and if there's a passing of the patient from the fire side to the EMS side, the whole thing is fluid. And it's not going, well, we would have done this over here, and so they start over, or it doesn't make a lot of, it should be constant to me.
Chief Burton, can you speak to that need concerning Augusta?
So I'm glad you mentioned that because I truly feel that interoperability is a must. And that coordination of efforts as it relates to monitors, for instance, soft goods, all of that being a seamless operation really results in better patient care. And so a lot of those logistical items I think we'll need to work through, and how those soft goods are restocked and those sorts of things, we'll definitely need to work through.
Totally, Chief. And on the restock item, right, what we're traditionally used to seeing, other than narcotics, right, we typically restock fire. And the reason you want to do that is that if you start an IV and give D50, excuse me, or you're giving atropine or whatever you're doing, okay, and then we pick the patient up, usually there's a loss of charges, right? So we would be doing the same thing. So if we can restock you, right, it can go on our charge master. I can't do narcotics, right, and wouldn't want to do that. But other things I can certainly swap. We would like to not do it on the scene as much because the trucks are not rolling warehouses, really. But we can work out the logistics on that. But we would rather have someone restock the fire department, right? You know what I'm saying? A rolling, moving truck, so that our trucks are, because we don't have the chance as often to go back to the house to restock before the next call. So it's hard for us to utilize the supplies and then in turn restock someone on the scene. We want to supply you. Oh, excuse me. We want to supply you with your supplies for several reasons.
Yes.
Chief Burton, what is our current contract with the medical director? When does it expire?
The current contract is a typical contract that we do here in Augusta. It's a 3-year with 2 1-year options. And so, definitely it's something that we would really need to consult with legal as it relates to that, if there's an option for shared resources there.
We would have them under contract. Typically, we would have the medical director under contract as well, separate from the city county, right? But it would be, assuming that's okay, from legal side. But that's typically how we do it.
So you're just wanting to contract with the same individual?
That's correct.
Okay.
Yeah. Because we want continuity, right? We're not asking you to pay for it or anything like that. It would be our cost for our side.
Okay, thank you. Let's speak a little bit about unit deployment and how that process looks. As stated earlier, Daniel Dunlap, who is our 911 director, can also assist and speak to this conversation. But how do you foresee unit deployment looking?
When you say unit deployment, Daniel, can you help me? Is she referring to the posting plan, or are we referring to the starting up? Or static? Because we would have static locations, but we would be moving up constantly.
That would also tie into human resources,
yes,
as far as how you plan to staff those, the demand plan as far as it relates to system statuses, and so on and so forth. Sure. So now, Ms. Sams, if you wanted to ask your human resources questions surrounding how they would plan to staff those units.
Did you like how I answered that? It just kind of shifted, right? That's cool.
No, it's okay. I was just trying to make sure the deployment is actually the SSM plan, the temporal
yes,
plan, and the posting plan, which we would have to all agree on, the posting move-ups. And
speak clearly into your microphone.
Sorry. That's what we would have to clearly agree on, the move-ups and the posting plans. But
right. Yes, sir.
And Corey can help with the staffing because he's got it. Pretty soon it's all Corey's problem.
Thank you, Corey. For me, of course, I'm concerned about all of the citizens of Augusta who has previously had jobs up under another umbrella. So for me, I'd like to see what your model is for addressing those persons who are right now don't know what to do. And if you have a plan, if you have a line, a telephone line, a location that they can get in contact with you, please also, when you are talking to me about how you're going to do it in your plan, put that out there so these concerned persons can get in touch with you.
Sure, thanks, Ms. Elms. So we opened up our online job portal, and that's priorityambulance.com or centralems.com is where they can go fill out applications. So we opened up the portal for applications last Friday, the 10th. Since then, we've hired more than 40 paramedics and EMTs. We're going to do a mass job hiring the coming Monday on the 20th and the 21st, where we will do the hiring in addition to onboarding. So those folks that we've already brought on board, we're going to go ahead and do the orientation process and get them onboarded. And we've actually started working some of the folks that has already applied. So,
Not here, right?
right.
Or has it been hospitals or where? I don't know where you're working. Just where are we working?
Yeah, we're just working them locally as we stand up our units. So we're just they're helping us with other employees and getting those other employees onboarded and where they can go, and talking about the mass hiring that we're going to do next Monday and Tuesday, the 20th and the 21st. And that mass hiring is going to be at Hilton Garden Inn.
Okay, have you posted this information on any social media or with?
Yes, ma'am, we did do a social media blast, and it's been on the local media news stations as well.
Thank you very much.
And we're actually looking to do some billboards close to the hospital and right off of 20 and 520.
Okay, thank you.
You're welcome, Ms.
So one of the things we've got to make sure that we're not doing, right, and we've talked to Corey about it, is not disrupting the current EMS system as we're doing orientations, because we don't want to be the reason, transports aren't being made now. So we're familiar with understanding that we need to make sure that we're working with our orientations to not distract the current system.
Okay, we just wanted to let you know that we are concerned. We're concerned about all of our citizens in Augusta. And this particular population, of course, we are indeed concerned, and we want to give them some reasons to know that Augusta is just not hiring an ambulance service and leaving them out there. So thank you guys for your effort. Thank you.
Yeah. We need everybody we can get, honestly. As I said earlier, there's not enough paramedics and EMTs out there right now, and every day there's less, honestly. So.
I know this question may be, we may be early in the process, but do you foresee those units being equipped with 12-hour crews or 12 or 13-hour shifts?
Yeah, good question, Chief. I have no idea. I've warned the team. I'm going to look at them because I'll start laughing. I warn them all the time not to throw darts, right? So I want to know the data before I can get it. I think it will be a combination, though, Chief. I think we will have a base layer of 24s with a layer of 12s and maybe 10s and 8s. It just depends on how the demand peaks on the bell curve. And we've got to figure out, too, that some of the things I'm a little concerned about is we have the state data, okay, but we can see that there's been on the state data around 38,000 requests for services for the last several years, and we've seen a reduction in the transport percentages year over year over year. So call it from 28,000 transport percent, that many transported, to 21. We're anticipating that's because of lack of availability of assets on the road to cover those. And if we're looking at the state data, and it's based on call received or call dispatched, right? I've got to work with Wasco because our bell curve could be pushed back, right? So if the patients were really requesting service 45 minutes ago or an hour ago, but we're staffing for this, do you follow what I'm saying? We could be off. So that's some of the questions, but to answer the shift pattern will be dictated based on the demand in the bell curve.
I had a question also regarding the shift pattern. So is it going to be like an ABC or an ABCD shift pattern?
Yeah, I don't know. I don't think so. Corey, what do you think?
Well, and it's going to have to be structured according to the needs of the county. For instance, in Hetzibah, and am I saying that correctly? I've been there, right? Might not know how to pronounce it. You're going to need a 24/48 shift there, where they work 1 day on, 2 days off. But when you get into the downtown areas, I think that the units are going to be so busy that I think that you're going to have 12-hour units. And when I'm saying think, that's because I'm the guy that throws the darts that he gets on to me about. But that's going to be typically what you're going to see. So you're going to have a hybrid model where you're going to have some 24-hour cars and some 12-hour cars. We think 24 and 12 is the best. We don't like to do 8 because it takes a unit out of service for a while to do a shift change, and that kind of wastes the time. So we try to overlay 12-hour shifts. Once again, once the consultants come back and say to us, this is where your needs are in order to meet the response times, then we've got to develop the schedule to make that work, and we will. Do you have a preference on those schedules, or do you think that there's a better way to do that?
No, I was just wondering what you were going to do.
Okay.
In addition, how are we going to financially incentivize them? Has that been thought about or discussed?
From a standpoint of what?
Of wages comparatively to the surrounding counties and.
Oh, that's a good question. So okay, we know what's happening now, right, around the surrounding areas, and we're offering pay based on that. But given the fact that most of the costs associated with this whole system is labor, right? It truly is. It's a function of how much we want to pay. So we wanted to put that on the committee as well, to basically say, okay, do you want us, because it translates into the deficit, right? That's how I'm trying to explain it. Do you want us to be aggressive? Do you want us to be normal? Right, you know, and as a committee, and because everything that we change is like a balloon. You push on one end, it sticks out the other. So I want to build the best EMS system I can within the means that the community has to be able to offer. So we'll be coming back to you as we continue to hire, to understand, because we not only, there's one thing attrition, right, but there's also, we want our employees to be part of the community and to stay here, right? It costs money for us to retrain, rehire, and constantly have orientations. There's a huge cost in that. So if we can attract and keep employees, then I would like for us as a group to say, okay, we want to be the standard in this area, or do we want to be the normal in this area, right? And that's the real question. Do we want to attract, or do we want to maintain?
Do I understand your salary package to then be wrapped into what the overall subsidy amount would be?
Yes, ma'am.
Okay. Sure, go ahead.
In your business model, do you have anywhere where there's expansion for non-emergency transports? Or would you use the existing 911 system for that?
No, we're actually saying this should be a separate system. We're only attacking the 911 now. We don't want the trucks to be utilized for in a facility unless the committee says there's a patient at hospital A needs to go to hospital B for services that are not available, that is a critical care patient or something of that nature. It could be considered an emergency within its own right? You know, that the committee would say we're blessing and authorize the trucks to make these types of calls as well, which would be handled through the dispatch area, not on us. But in general terms, we do not believe these trucks need to be used for non-emergency at any time, and they should not go out of the county. This should truly be in a facility for services not available, for services that are critical, and the patient would be in jeopardy in the event they can't get it done at hospital A.
And I would agree that would be something that's important to have in the contract, because we don't want to be in a position where the 911 center is denying anything that is something that's very critical. But at the same time, not have any kind of response for 911, obviously.
Right, that's right. So one of the things to keep in, you're exactly right. One of the things to keep in mind is the patients in the streets don't have any care at all. The patient in the hospital has care. Okay, so we look at it as our first responsibility is to take care of the citizens in the street and in the ditch and at home, and the ones who don't have care. We understand there is a potential patient that might have to have something that is critical, but to me, that's where the medical directors come in and say this type of patient is something we would agree that is potential dangerous if we can't get them to hospital A, or B, excuse me.
Sure. And Daniel, what we've operated in some other communities, our philosophy and our program is unique because we actually separate the 911 units from the hospital interfacility units. The interfacility units, although they may have paramedics and they have all the emergency equipment and care, they, if the system is overloaded in 911, can come across and help 911, but that's a one-way valve. The 911 units cannot go across and run the interfacility calls unless it's the type that you just talked about and described. And what you do then is you assure yourself that the number of 911 units you have are going to be utilized for your 911 calls, and that's what helps to guarantee your response time. And that type of system is what we want to design for your citizens of Augusta, or for your Augusta, Richmond County.
Sir.
Does this plan have any quick response vehicles?
Yes, ma'am. We plan to have 3 QRVs. Once again, we look to the committee to give us advice, but we expect for those units to have paramedic and ALS services on those units, and then the ambulances to have a BLS driver and either a paramedic or an EMTA as the person in the back of the ambulance to take care of the patient. And that's how we envision the program to work. And then if you get out and there's a critical call or a critical call is dispatched, the QRV goes with quick response vehicle. QRV goes with the call at the same time. The dispatch center would dispatch them simultaneously.
So can I let me just add to that. The number of QRVs will be dictated based on Washco and Associates. Let me 3 is based on your plan you have now, okay? 3 can change, right? If Washco says, here's what it is, and we've got the state data that dictates the type of call, right? Because my wish is that we had enough revenue, right, that we could afford paramedics on every truck, and they were available, okay? That's not a reality. For my statement earlier in life, that's not reality. And so we have to build a system. The QRVs with paramedics on there are truly there only because the system's not able to staff this United States wise. Okay, it's just not just here. Okay, it's a system designed to basically make it more efficient to utilize and get the streets covered with medics, or EMTs I should say, when you don't have enough. Okay, paramedics. And so if we could endeavor ultimately to grow our own, train our own, recruit our own paramedics, we'd like to have paramedics on every truck. Okay, that's the way it should be. And we'd like the system to be able to pay for it. There's a couple parameters we don't know yet. We don't know if there's enough revenue. We don't know if there's enough staff. If there's not enough staff, QRVs will be what we have to do to make sure that we get the right patient, the right care. But make no doubt about it, if we only have EMTs, it causes a couple of problems, okay? There is a transfer of care from a medic-based fire engine to an EMT, okay, problem. There is also an ALS assessment fee that we lose as a system here that we typically get to have if we're running paramedics. So there is a decrease in revenue if we only provide EMTs, okay? EMTAs do give us an ability to do an ALS assessment, but there's not a lot of them. We're going to try to train some of them. But what I want to be transparent about is the right system ultimately should be a paramedic on every truck. But we're probably going to come to you with something different than that because it's not available. Just being honest.
Thank you for that.
Well, I'll say that nationwide, we've seen where those tiered systems have been beneficial to communities. And so building out that tier system and down the road incorporating things like community paramedicine and those different types of programs that really realize benefits for the communment.
So Chief, if I can add on the community paramedicine piece, I want to make sure this comes out right, okay? So I've not seen, excuse me, I have not seen a community paramedicine that is funded, okay? That's the reality. There are a lot of things that community paramedicine can address and take care of. As I said earlier, there's an access to care issue across the United States. The most vulnerable population is the Medicare and Medicaid population that are just trying to figure out how to access health care. Community paramedicine can bridge that gap, but we have to have a payer. Absence of a payer, what we have decided to do as a company is we've worked with the Georgia Ambulance Providers Association in this state. We were successful in Tennessee to be able to get legislation passed for us to be able to assess and refer. Different than community paramedicine. Assess and refer in the field for Medicaid patients. And what that does for us is the Medicaid patient that requests a service that otherwise is a low acuity patient, hence what people term wall time, ambulance patient offload delay. The reason those patients are in that holding pattern is they're more likely the lowest acuity of patients in the ED, some of them, okay? And that means the physicians, nurse practitioners, and the staff are working on patients that are much sicker. So what we have is patients that are sitting in the ED with an ambulance crew tying it up, which otherwise are really just looking for, how do I get my blood pressure down? How do I get my medications refilled, right? And so what we've asked the state of Tennessee to do and pass, and they did, is legislation allowing us to get paid as if we transported them, hence their unit gets back in service faster, but refer them as long as the patient consents, to refer them with medical protocols, with our medical directors, to a mid-level or a physician, EMS physician, to give them what I would consider low acuity type care in the street, where they can say, yes, I don't need to go to ambulance. The patient has to make this decision. And then we consent to a telehealth, and then that in turn, the patient gets their meds refilled, he prescribes, or we have them delivered, okay? Now, Georgia, we've been working on that in Georgia with the Ambulance Association, and we have promising momentum, okay? I would say that everybody understands that there's a huge efficiency in getting the patient to the right place at the right time, and those are the patients that we really and truly, I think, could really help and get them into the healthcare system that they need through our telehealth provider. That's right. So our EPCR, electronic patient care form, has direct link to our telehealth. We own our own software. We have our own practitioners. We have our own physicians for that. We don't mind working with the hospitals. We'd be happy to. But our history has shown that most of the patients that when we do a telehealth to a local hospital system, which we're not saying is the case here, could be totally different, but has been that those physicians are tied up on high acuity patients, and it's harder to get service to them timely in the street. We need physicians, nurse practitioner intervention within 6 minutes of request from the crew. So once we have that, then we can give them immediately a telehealth visit. They can get what they need, or the physician, nurse practitioner can say, no, this patient doesn't qualify, transport them, right? So they're in total control, but we're not doing more interventions. The idea is to find the low acuity patients and get them quicker treatment without clogging the system, but also give them better care faster.
Thank you for that, Mr. Gilmore.
I have a question.
Yes, ma'am.
Mr. Gilmore.
Gibson. I like Gibson better.
Mr. Gibson.
Gibson, my apologies.
Okay, I'll go by Happy Gilmore any day.
Okay. The model that you just talked about is very intriguing, and I think California is currently doing it.
Yes, ma'am.
Okay. I'm concerned because there is a population here in Augusta that might not be computer literate. That may be me. But there are others that might not have access to a computer. So how do they get trained on this model that you are talking about and be expected to receive what they need?
Yes, ma'am. So, good question. The system that we've designed that we prefer is the ambulances goes as it would normally go. There's no change in the dispatch. There's no change in the request. The ambulance goes as it would normally go. Once the personnel are on the scene, whether it be fire or whether it be our personnel, they can say, this patient is a candidate for telehealth. Of course, we'll train them with that with our medical directors. They'll understand that. We've got to do, I think, in our program, again, transparency. Right now, the standard is alert and already ×3. Can they make the appropriate decision for telehealth, or do we need to go deeper down for some type of independent decision-making skill assessment? that we're also working with, actually with Cornell, to develop for our staff, that we can actually say, okay, here's a list of questions we can answer. This patient meets the needs. This patient can make an informed decision. And then that's with the paramedic, with the team on the scene. And then we just flip our screen around. It'd be like taking our computer that's there, and they don't have to have technology. They don't have to know how to use it. We're hitting a button. All our H&P, all of our notes are going directly to our telehealth software, which the mid-level, or excuse me, the new term is advanced practitioner, or the physician turns it around and has all the data and says, okay, XYZ patient, how are you? So there's no training for the patient. There's no technology needs for the patient. We're bringing it to them.
Thank you very much.
Yes, and I think, Dr. Abel, you have a program here already with telehealth, and certainly you got your first responder as you were the physician out into the field and into the streets with an emergency vehicle, and that's very unique, and your community should really appreciate what your hospital is doing with that. But your system now, do you find that that works well for the patients, the telehealth part?
So currently, the EC3 model, we're just entering that stage. We haven't taken that fully on yet. Currently, we're doing multiple other projects with telehealth. Like you mentioned, we have the ICU care to the rural hospitals, and we have virtual care at home, where we have patients that we discharge from the hospital that we send home and monitor them virtually through the telehealth program. Two very robust programs ran through telehealth at AU, and we can talk about this on the sideline, and we can make introductions to people who run those programs, and you can see our equipment.
Yes, ma'am. And I guess I would like to ask you, because you're on the committee, and the committee helps us make all of our decisions here. They're not all our decision. It's what the committee would like. But do you think that this is an idea that would work and something that would be helpful in the 911 system in the community?
To access telehealth, the telehealth?
Telehealth on the ambulances, yes, ma'am.
Oh, yes, of course.
So it's important for me to note that this isn't day one, okay? What it really is we've got to provide basic bread and butter ambulance service to your patients when they request it first. That's my goal first. My second goal is to then start taking it, there's a whole social aspect to this, quite frankly, that we're going to have to work with what I call patients that continue to access the health system through 911, that we are going to have to address, and we can address that once we get going. But fundamentally, first, we have to start off with the basic bread and butter, getting a patient, as Gary would tell me, when the phone rings, 2 butts in a seat, an ambulance on the scene within a reasonable time. That's the first goal. The second goal is to then be creative, to try to figure out how in the world we can help the patients that really need access to health care without dialing 911. And there's a whole social side of that, probably a social manager, follow-up care. There's people out there that need heating oil, that need gas, that need electricity, that need water, that are calling food, that are calling 911, behavioral health, are calling 911 when there are potentially other ways of handling those repeat patients. And those are much larger problems to tackle. I don't have all the answers for that. I'm just saying I don't want everybody to get too excited yet, right? We're just willing to go there. We know that we've got to be more efficient in EMS. We got less resources, and everything costs more.
Just because I'm not familiar with the telehealth, is that an option to be used on the front end versus once a unit has been dispatched to the site?
Yes, ma'am. There are programs out there that, do nurse navigation programs at dispatch. It's a user preference. So you can actually do through EMD Clausen protocols. You can look at the patient and determine that this patient does not need an ambulance. I mean, I'm a little biased. I'm scared of that from a liability standpoint of view. So I tend to say, I'm an old school medic. I got to touch you, see you. You know what I'm saying? But that doesn't mean my way is right. Okay, so I'm open for that, but yes, there are nurse navigation programs. You can do telehealth in the front end. It's what I get worried about in those programs, honestly, is that when someone dials 911, it's hard to say I'm not coming. You know, I think the citizens, in my view, I'm not saying it's right or wrong, okay? I'm just giving you my point of view. I would be remiss if I didn't. I get scared when I don't show up.
Director Dunlap, I see you shaking your head pretty heavily over here. Can you speak to your concerns surrounding
I was not
it?
falling asleep or nodding. No, for real, because that's something we never want to not take action on the call. So if we receive a call asking for any resource, whether it's law enforcement, fire department, medical assistance, we don't want to put them off on something that we no longer have control over. And I think that's you're echoing that same sentiment.
Yeah.
I was likening it to a Ask a Nurse service in which you could just call from home. Okay.
Yeah, absolutely. Totally agree with that. And I think there's a whole other aspect, right? That we get them in the right programs, we get them in the behavioral programs, the managed care programs want them treated a certain way, get them in the right programs. If that's the case. I mean, we got to get in here and start transporting and understand where the need is before we.
Sure. So in speaking earlier, I told you that our fire chief, Antonio Burden, will act as our contract administrator. And Augusta has already communicated a need for a emergency advisory board. If we're going to move along with the path to have a joint medical director, who would then act as your representative concerning Central here in Augusta?
It would probably be Corey, is what I'm guessing. Corey.
Now, as it relates to...
If it's a problem, it's Corey. If it's praise, I'll come.
Okay. Thank you for that. As it relates to required reporting, a lot of the reporting requirements Augusta has previously communicated would be void in this sense because Augusta would be doing the dispatching directly to your units. So in that same vein, do you have a indigent report in which you would be able to provide to Augusta on a monthly basis so we would be able to account for how many residents or visitors have not paid for service?
Absolutely. So we'd be happy. We call that uncompensated care, whether it's indigent, insured, non-insured. You'd be surprised, right? There's a whole uncompensated aspect of it, deductibles not being paid. I could go on and on, right? So we have no problem. That's the whole idea of being transparent in the revenue side, so you can see where it is. And back to your data request, I don't think I answered it earlier. You reminded me. The data request from response times and all the reports, not only clinically, right, but also from a response time point of view, will be housed in the dispatch in your CAD. So we'd be happy to help get report writers if that's what we need, but you're having the data.
Okay. And in addition to reporting, we'll make sure we add this into our draft contract that we are working on now. Do you also have a report for calls in which you were dispatched, yet it did not result in a transport?
Yes, ma'am. We certainly provide that. If 911 can't, we can. There's going to need to be an interface between what 911 is doing and what we need. And 911's, we have some software, and I don't remember the name of it, Corey, but it's the go-between software between the CAD and the 911, and it basically bridges it. So whatever they do in 911 ports directly into our CAD, so we have it for our own records as well. So, I'm sorry? Yeah, from the PSAP, but it runs the reports, but it also, you can run them, or if you can't, we can. We have a data warehouse, and we can do it both. We also need that interface for billing purposes. There are some things that 911 will need to do to make sure that we are able to bill appropriately, and that's to basically do an ALS assessment. Was it dispatched emergency? We have to have certain questions asked that helps us get reimbursed from Medicare and Medicaid, and so we don't want to lose that. So we'll be working. The long answer is both systems are available to pull the data. How's that? I could keep going. So.
Thank you for that. And I would like to clarify that while a decision has not been made concerning the use of a joint medical director, that would be your preference. But again, a decision has not been made regarding that. Committee, do we have any other required reporting needs that we want to make certain won't be a problem in our draft contract?
I think the only other question as far as reporting needs are things that need to go to the state, but that's going to be all through your PCR. Okay.
The NIMSIS data will come through us, right?
I'm good. Yeah. Right. Okay. No, I'm good. Yes.
While the EPCR, the patient care report goes to the state, you also can get that information from the state at any time you need, and they'll give you a computer download on that information.
Just being familiar with the EMS Council and some of the reports that are required as far as, the hospital, times, meeting some of those times where it comes to, and I don't want to steal your thunder because I'm already reading your paper over here, but I'll go ahead.
No, you can go ahead, have it.
Well, just when it comes to STEMIs and strokes and things of that sort, is that what you put?
Yeah, I was interested in the integration with hospital QI programs with regards to sepsis, STEMI, stroke, peds, trauma, burns. Would we be able to incorporate that?
Yeah, and you also can access the system and download that info into your computer. And then, of course, we want to look forward to the CQI program till we drill down on that and we say, all right, we see problems in, this particular area. Maybe it's STEMIs or maybe it's stroke. And then we want to know what we can do going forward for our, look at our objectives on how we can better take care of a stroke patient or how we can better take care of the STEMI patient. And then with the hospital, we'll go side by side and try to develop those programs.
Wonderful.
So one thing related to the STEMIs and the stroke programs, right? So a lot of that, if we're providing, depends on our staffing model, right, that we ultimately end up with because of what we have available. But if, for example, some hospitals trying to get accreditation for chest pain, okay, we would, if we're not the medics, right, we'd work with fire to document the aspirin was given, the 12 lead was done within so many, that kind of thing. We'll turn it over to you. Not to get to the next phase because we're not gotten phase 1 anywhere near done yet. Phase 2 is the hospitals. So we own our own patient logistics software that it's embedded in Epic and Cerner. And so we want to make sure that you have all the data hospitals do for their various accreditation programs, assuming the committee wants that, right? So I don't want to be because a lot of it's honestly going to be coming from fire sometimes, right? And so we would need to be able to have some way of transferring that to you.
Now concerning technology, we have radio systems as well as EMDs. Tell us your proposed plan for your technology needs.
Okay, so the radios, I want us to be very interoperable with fire throughout the whole community, right? I'm not understanding exactly how, so I don't want to speak how the current provider is doing it. It would seem better to us if there's room on the current EMS system, CAD, without being cluttered related to fire's needs, that we were able to have the same system right in place. We would buy the radios, we would get on the same system, we could switch over and talk if we needed to. So there's a way to have, I don't want to tie up the fire chief's channel, right, running our calls all day. And hopefully we want to have silent dispatch. So if you have MDTs that are available, we would like MDTs from your system put in our trucks. Of course, we would pay for that so that we're having silent dispatch. And we will have the right equipment in there to talk, right? So if we could do that, that cuts down on some of the chatter. But we would have to have some kind of redundancy. But the answer is we would like to be on the same system the county's on, so it's interoperable.
Okay. Chief Burden, concerning access to our same radio system with the fire department, do you have any objections to that request?
Oh, absolutely not. I think it's essential. I mentioned interoperability. For us to be able to communicate utilizing those same dispatch channels for our men and women that are boots on the ground, so to speak, that are working together, I think it's essential for them to be able to communicate. It just makes for better patient outcome, I believe.
Perfect. Thank you.
Chief Allen, can you speak to radio usage or any other type of technology needs or questions that you may have surrounding Mr. Gibson's request today?
Thank you.
In regards to the radio system, that would be no problem. So we can definitely accommodate his request in regards to those needs.
Now, Mr. Gibson, you stated that if needed, you would be able to purchase those radios. What's the timeline? Is there a lag in time from him purchasing radios? Would there be a need for you all to use Augusta's surplus of units?
He would actually, as he stated, purchase the actual radios. We would have to go into an agreement with him, but he would have to pay the subscriber fees. Those actually run between $46 to $48 per month. And that's what our current provider is currently doing as well.
And Mr. Gibson, is it fair to expect that there would be a savings produced by you utilizing Augusta's network and our communications system that would be accounted for in your financial model? Thank you for that. Thank you, Ms. Allen.
You're welcome.
We will need to get the details on the radio specs and how much they cost and all that, other than the monthly fee, right? If you have, anyway, we can work it out. I just don't know if I'm using surplus radios or if I'm buying radios, I just need to understand the cost. And
Yes, we will get you that information.
thank you.
You're welcome.
Yeah, and just for your information for the committee, ordering radios, sometimes you have back orders, or sometimes it may take more than just a few weeks.
Sure.
I'm just going to pull a number out of the air. If it takes 4 months, 5 months to get the radios in. Corey has a system now that he's ready. In fact, his crews have been down here doing radio tests throughout the county to make sure that we can transmit and receive throughout the county. We would put a radio in the 911 system that could communicate with all of the ambulances and vehicles, so we'd be ready to go, ready and able day one, irregardless of how long it takes to get these radios in. The other is the ultimate in system, the communication with the fire and the 911, yes, but we can operate from day one until that system is put in place.
Ms. Allen, do we have a surplus of units, radio units available in the need that we needed to deploy those units today?
Yes, we do.
So there may not be, just to ensure that it's seamless, because we know that the radios that IT currently has works perfect with our current system. But that is another option, so thank you for that. But I would expect information technology and Central to work through those logistics.
That's correct.
Thank you.
Thank
Mr.
you.
Coker is correct. It does seem to be a delay sometimes. They are on back order sometimes, so
Thank
he's
you.
correct.
And I'll just say from an interoperability standpoint, we appreciate, you coming out and doing those testing, but we would certainly want to use those resources that we have available just so we can go out of the gate, not having our dispatch having to use two different radio systems and back and forth and information get missed, because there's that potential.
That's right.
And you already stated that GPS is standard, so that is of value to us as well. But what about your demand plan or a system status plan? Is that, I'll let Director Dunlap speak to that matter.
So that kind of goes back when we were talking about unit deployment, and it kind of got brushed over. I made a joke, but here we are. This one of the things is we're going from previously with the contract wanting to track units to now actually confirm where the closest unit is to dispatch. The ability for that system status and posting and rotating and ensuring that we do have the closest units not only available to go to the emergency call, but just predicting where we need to put those. So does that go back to Marvelous?
It does. Yeah. It goes back to two things. Marvelous can certainly help with that, assuming that's what we end up doing. Your MDTs, I don't know if your current MDTs have AVL GPS on them or not. I'm assuming Fire has AVL GPS. I don't know. But if your MDTs will provide the AVL GPS, we can use that, or we can do our own separate modem and transport, whatever. Not transport, but own the transport unit, a separate module that just tracks. That can be as long as it integrates with your system, right? So we don't care if the MDT works for that purpose. We just believe there has to be GPS AVL. For your point, that we've got to be able to we got to know where the trucks are. We got to be able to move them. We got to know they're there.
Sure. And I don't want to overstep and ask Ms. Allen, because this goes back to the use of MDTs, and would that technology be available for their use? Do I need to go back through the chairwoman, Madam Chair, to ask that question?
I'll allow it.
Wait, point of personal privilege. Actually, I just wanted to say that.
Okay.
All right.
What was your question, Mr. Dunlap?
Just in regards to the availability and use for MDTs with, the New World software, the Tyler software, If there are, and again, this gets down into the weeds with if they're laptops that they're providing with the software that we're providing, or laptops that they're utilizing with the software that they would be paying for, just so they have that capability. If it's on our system and they can do some of the things that they talked about, like silent dispatching, to where they can hop on the truck, they can click the button to show themselves en route, click themselves to show themselves on scene. That information is coming back in through CAD. We can see it, and we're transferring that information and data back to their system for billing and what have you. I just want to make sure that's available.
That is available on the system right now, isn't it?
Short answer is yes.
Short answer, yes. Okay. All right. Very good.
Do your MDT.
Okay. Well, and that also goes back into also the as far as the unit deployment is use of first responders. Whereas now we're having to either automatically send them based on a call type, or have the local provider let us know if they're needed or not, whether it's immediately on the call, or it could be several minutes or a time frame after the call is already completed. As far as the 911 call, I want to mention that. But what that also will do was leave those fire department resources available, whereas now they could be tied up just because we don't know, how long it's going to be. So,
yeah,
that's all I got.
Thank you for that. Concerning your business model, we have a existing contract with our provider that, one, requires a 30-day notice to terminate the contract, and two, because your anticipated start date is May 8th, we compensate our current vendor on the 1st of each month. Do you foresee a need for overlapping in the event of technology challenges or any other operational delays?
No, ma'am.
In saying not, can you move your start date up to May 1st versus May 8th?
Corey can answer that.
Yeah, I'm trying to think about the logistics on the software, but on the, yeah. I mean, you can. From
So yes, to answer your question, yes, we can. We're actually ready by April the 8th. So yes, May 1st would not be a problem.
Committee, do we foresee a need just to ensure maybe the last 2 weeks of April having an overlap of Central as well as our current provider, just to make certain that there's not any problems? How do we see this transition from one to another? I don't want this to be like the flip of a switch. They call 911 and there's no one to dispatch. Have you encountered this in the past? If so, what are your best practices that you can discuss?
Yes, ma'am. I do believe that your suggestion of an overlap is really a good idea. Daniel, do you have some comment there?
No, I agree 100%.
I think that's the way to do it. You're right. The flip of the switch is tough. That's normally how we operate. And normally, we get that call at the last minute and say, okay, we've got to go quicker, and that's a problem. The more planning we have, the better and the smoother that this will go. And so we can operate in any way that you want to do, but we'll be ready, and overlap would be good.
If one of the things we've got to be aware of is that the current provider is in a tough situation. Okay, so they're in a lame duck situation. So we want to make sure that they continually can staff as much as they can. We want to support them until we can change over. I think Gary's right. We typically, midnight on a certain day, we flip the switch, and that's what happens. We're prepared to come if we need to. We're prepared to come if we need to. I want to caution, though, that all the things we're talking about, right, if you say April date, I've got to make sure, we're here. Okay, I'm not saying that. I just want to make sure that we've got a lot of technology to put in place, some training to put in place. So that's what I'm more concerned about, right? Can we get Marvelous up and running? Can we get the technology going? A radio and a truck and personnel and an ambulance in the streets we can do immediately today if we had to, right? We don't want to, but we could. But to do it right, we still would have to have work to do, right? Even from the date that Corey gives. We're not going to be ready with all of these systems we talked about on that date.
And please note that this is a subcommittee meeting. The decisions here today are not final. This is an introductory discussion. So I wanted to make certain that we understood your flexibility if there was any. So we appreciate you speaking to that. Concerning any other business model needs, Do you have any other comments surrounding it? I know the transition piece was of high importance to me.
No, I think you've addressed most of the concerns I had and questions I had related to HR. You understand where we are from the human resource standpoint of view. We've addressed the whole aspect of subsidy and why we're asking 10% versus a subsidy. We can do both as requested. We've acquiesced and believe the technology you're asking for and some is the appropriate answer. I think GPS AVL is a must. Communications has been addressed. Financial model, the rates we've addressed. Protocols, we have a question out on mutual medical director, I believe, that we'd like to get covered from the legal side, from y'all's perspective. But we're available and the team's available for any more questions now and in the future. And we're probably going to get with individuals, assuming we can, with the chief and 911 to start hanging out more of the details and the implementation plan.
Yes, ma'am. On the business model, just to give an overview of from our side as to how we see this, is to number one, let's take a clean sheet of paper and take a look at your 911 system as regard to ambulance, and let's develop a system. We're asking you to help us to develop that. What do I mean? What response time do you want? How many ambulances will that take to make that work? Yes, the consultant should be involved to do that. How do you want your system to operate? How does your 911 center see doing that? All of that about the operations. Let's get the operations set. The next part is to come in then and decide what the budget is and what it's going to cost to operate the way that you want your system operated. And then we look at those two and say, all right, do we have enough money in revenue to take care of that? Revenue comes from two sources. Number one, each time we run an ambulance call, we send out a bill and we receive the monies in from Medicare, Medicaid insurance. You have a pile of money and that's your revenue. If your revenue is less than what it costs to operate the system that you've developed, we have to ask for a subsidy. And keep in mind, if you're asking for a subsidy here, that the more ambulances you have, most likely will mean the lower response time, right? But also remember, there's a seesaw here to balance. Also remember that the more ambulances you have, the more the system will cost, even though there's no more revenue coming in from the number of ambulance calls, so the subsidy will go up. So if we put a system together where the subsidy gets too high, that's a problem. If we put a system in where the ambulances are not enough ambulances to respond to the call, that's a problem. And we have to take this seesaw and balance it to give the citizens what they need for response times and quality care, along with making sure that the county government doesn't spend too much money. That's the challenge that we have here, and that's what we're asking the committee to help us with.
Thank you for that. Are there any other questions from the subcommittee?
Just one other item I wanted to touch on. We briefly touched on I don't want to use the word middleware, but I kind of do. Talking about getting the data from our system into your system. If that's just a one-way street, that Mr. Thomas, I know we've communicated and put you in touch with the deputy chief information officers. I just want to make sure that they get that data accurately as to what is needed, because there may need to be an interface on our side as well. Yes. That's all I want to say. Thank you.
Thank you. So with that, our next meeting is planned for Wednesday. Oh, excuse me, Ms. Allen.
Yes. Could I ask that the committee, because I know we've talked about a number of things technology related today, and so that the technology department could be truly effective in getting this information back, I would like to ask that all the respective technology requests from EMS, Central EMS, goes through this committee and be forwarded to the IT department so that we can respectfully get that information back to this subcommittee, and all of that information can be centralized to this committee as opposed to being directly sent to us, so that we can make sure that we're clear on everything that's being requested and that this committee is actually clear on everything that's being requested.
Thank you for that, Ms.
We don't want to
Allen.
be the middleman. We just wanted to go straight to the subcommittee, if that's appropriate.
Thank you for that. We'll make sure that that chain of information is understood.
Yes, ma'am.
Thank
Thank you.
Thank you.
In closing, our next meeting is scheduled for Wednesday, March 22nd, 2 p.m. in the Linda Beasley Room. That's on the first floor of the municipal building. In the meantime, we will ensure that Central is able to receive the information that you've requested today, as well as the items that you need for information technology, as well as the transition information and the joint medical director. Those are the items that I have noted. We will also begin working on a draft contract. We have a couple of other contracts that you've already executed within other municipalities and ideas from Augusta. So we will start to incorporate those and start to have those conversations and look to see everyone next week, 2 p.m. in the Beasley Room. Thank you for your time.
Thank you.
Meeting adjourned.